Alrighty, let's get this show on the road.
Yep.
Hello, everybody, and thank you so much for joining us again for another one of our fantastic educational seminars. And today we have a repeat offender, the very, very lovely Dr. Divy Dua, with another excellent seminar. And I know that his seminars get watched over and over again, so this promises to be very, very topical and interesting. Today's story, as you can see, is current best practice or updates on mesothelioma. Dr. Dua is a medical oncologist. He's been with us for a while and he writes an outstanding report. So please keep him in mind when you need to have an assessment and IME report done. He specialises in thoracic malignancies, lungs, mesotheliomas and thymic malignancies, but also tumours of the breast, pardon me, and the central nervous systems and melanomas. He's recently had a very exciting new appointment, which has seen him move from the ACT to Victoria. So sad for all of those in the ACT who won't have him anymore, but very exciting for him and for the people of the Gippsland region in Victoria. And there will be time at the end for you to ask questions, but in the meantime, if you could please keep yourself on mute, and if you have a question, please pop it into the chat. Without further ado, over to you. Thank you so much, Dr. Dua.
Thanks, Michelle, for the introduction. As I said before, I'm Divy. I've been doing this for a while, medical oncologist for about 10 years. I did my fellowship back in lung and thoracic malignancies back in UK at the Guy's Hospital and Sarah Cannon Research. So the topic for today is to understand what's mesothelioma, what's changing, and how do we actually approach the patients. So I think the agenda for today is just to talk about how we diagnose, how we stage, what are the treatment choices, what are the new treatments, and where we're going in mesothelioma. So mesothelioma is relatively uncommon. It is not a cancer that you see every day, but it is not that uncommon cancer that you actually do. In my practice previously, or most recently, it was easy to see 1 to 2 mesothelioma patients per month. It's still predominantly in the male, that we're still seeing a latency period for the asbestos exposure that happened in 1970s and 1980s. Usually nowadays you see most commonly in the 6th to the 8th decade, but as the profile changes, we're starting to see people in the 40s and the 50s as well. It has got a very strong association with asbestos in terms of the causation factors. It is a very difficult cancer to diagnose. It sometimes takes a lot of time where the people just present on multiple occasions with just acute shortness of breath and scan. It's just the acute shortness of breath, and they've had multiple episodes of fluids being drained. The biopsies can be equivocal, although on the clinical grounds we have a very strong suspicions for a cancer, but it takes a long time to actually prove it. There's a lot of markers, or these are the stains which the pathologists usually do, and that's the marker to exclude this. So TTF1 at the bottom excludes that this is not lung cancer, CE excludes it is not bowel cancer, and specifically these combination of 3 stains makes it positive for mesothelioma. One of the other things to actually also mention at this point is that the mesothelioma has 2 different components, or two different subtypes, epithelioid and non-epithelioid. Historically, we've always said that the epithelioid seems to work better with the chemotherapy, and non-epithelioid or the sarcomatoid seems to be the one which has got more which seems to be more aggressive, and the prognosis is poor. But that seems to have been changed, and as we go forward with the newer treatments, the aggressive version seems to actually do respond better to the other newer generation treatment. So the things and the paradigms in mesotheliomas are changing. There are, like with any cancers, you always have a tumor suppressor gene which tries and control any cancer cells which may develop in the body, and any kind of a mutation within that cancer you can actually cause the cancer. But this is not specific to mesothelioma. We don't tend to check routinely for tumor suppressor genes, but this is part of the next generation sequencing and has not made any changes to the current treatment. So generally, the one of the differentiation that we have to make. So mesothelioma is the cancer of the lining of the lung. It has got nothing to do with the lung at all. It is the cancer which originates in the lining of the lung. The similar lining of the lung can be continued on to the abdomen. As you can see, the lining continues along the abdomen as well. Although it sits in the abdomen or the tummy, it is still called as mesotheliomas. Anything which originates within the lining of the lung is called as the pleural or the lining of the lung or pleural mesothelioma. And one which originates in the abdominal is actually called as the peritoneal, but it is still classified as mesotheliomas. Mesotheliomas cause local problems. They tend to wrap the lung around it. They can wrap around the blood vessels. They can literally squeeze the lung through, but they are very, very unlikely to travel. If you would have asked me about 8 months ago, I would have said, look, there is 100% chance this cancer will not travel. In the last 8 months, I have seen people with the brain metastasis, but that's extremely rare and known only in the case reports. So usually the chest X-ray, scan of the chest, the fluid lining, etc., is all how we do it. The PET scan and the head imaging are becoming common, but they're not a standard. They're not a standard of care. Obviously, how do we diagnose it? We take some fluid in the lung, we look under the slides, and thus you make a diagnosis. Sometimes you have to do a bronchoscopy or a camera test within the air lining. Sometimes you have to put a camera just within the chest cavity to have a look at it. So it is a very difficult, it is more a clinical suspicion. If you really believe that this patient has got a significant asbestos exposure, symptoms and scans suggestive for mesotheliomas, you ought to keep persisting. It is not unlikely that it takes 3 or 4 attempts to make a final diagnosis of cancer. As you can see, the fluid in the lining of the lungs has got only 1 in 3 chance of making a diagnosis, 33% rate of success. VATS is video assisted thoracic scope, where basically you make a small incision within the chest cavity, you put a camera through, and then you actually and then you take a biopsy where it is. And also you can put something at a point where you can seal the lining of the lung. So the lining of the lungs has got 2 linings. Our lung has got a lining which just next to the lung, and then the lining sits between one of the attached to the chest wall as well. And that's the cancer originates within that space. You can put things like talcum powder, etc., which will just seal that space, and the cancer can stop growing, or the fluid can stop accumulating. So when I started training back in 2010, we had a hard time convincing the respiratory doctors to actually even refer these cancers to medical oncologists. At a point of diagnosis, the respiratory guys would tell patients, you diagnosed mesothelioma, you should go home, enjoy your life, and you've got 6 months to a year to actually live. And there is no treatment, which was not entirely true, but it took a long, long time for us to convince the respiratory doctors that we can actually make a difference. There were a lot of failures in the clinical trials. Finally, we found a drug which worked, and eventually now we've got many successful treatment as we will go forward. So somebody who has got diagnosis, obviously any patient with cancer has got a choice of no treatment or basically just treating symptoms. Obviously, you've got a choice of multimodality treatment, which is basically meaning trying to treat with chemotherapy, radiotherapy, surgery, etc. Some people are not suitable for multimodality treatment. Some people are basically have multimodality treatment, including surgery as well. Surgery in Australia is not very conventional for mesotheliomas. As you can imagine, it is a lining of the cancer. So you basically have to remove the ribs, the muscles, the lungs, and strip the lining of the lungs. And what we call is a decortication surgery is that is only reserved in a very tertiary centers, and it's a very uncommon surgery with an extremely great risk of morbidity and complications. So obviously you've actually found a cancer and mesothelioma which is suitable for a multimodality treatment. Then you do a pleurodesis, which is basically sealing the lining of the lungs. Then you actually give them chemo, shrink the cancer, and then you continue on with and then you do a further surgery, and then you continue on with the chemo. That's probably what we call is a multimodality approach as much as we can. But majority of the cancer fall into this category, where you've got a cancer which is basically unsuitable for surgery or upfront chemotherapy or a combination therapy. The standard of care for anybody who has been a good performance status, meaning that is completely as normal as the person can get to. And as you get to the performance status 2, 3, it means it's spending a lot of time in bed and they're not able to manage. Somebody who's got performance status of 3, which just means they're spending 50% of their daytime in bed. And whereas the PS2 close to around 25%. As you can see, the standard of care has now changed. We treat everyone who's got a good performance status, who's relatively unaffected by the symptoms, with the combination of ipilimumab, nivolumab, which is the combination of immunotherapy. There are other choices such as chemotherapy with the drug called as the bevacizumab, which is the monoclonal antibodies, etc., who have that has got some benefit and who have got complicated, can't have the immunotherapy upfront as well. Subsequent to that, people who progress on the first line of treatment, then they've got multiple regimen, but the response rates lies between 10 to 20%. Failing that one, if nothing works, then I think we should be offering all our patients the best supportive care. As we can see, this has become a lot more complicated. There's a lot more drugs which we can use. It is one of those cancers which we can treat. Yes, we can't treat everyone. Yes, we can't treat everyone. Sorry. We can't treat everyone, but we do have enough treatment regimens that we can actually do that. So just to be on the systemic therapy, which is basically how we treat people in terms of our immunotherapy and chemotherapy. So this is chemotherapy. We've been trying to give chemotherapy in mesotheliomas for about 25 years now. Chemotherapy is the standard of care, whether we give it in the first line or second line of care. Chemo, as you can see, the response rates sits between, so 1 in 3 will respond from chemotherapy, and platinum agents with either cisplatin, carboplatin, etc., are the basic backbone of the chemotherapy. And then you can add a second agent, and pemetrexed was a drug which actually showed in 2007-8 that was the first drug that actually made a big difference with mesothelioma. We tried everything. Largely the history, the way we've not actually made a huge difference is like the breast cancer, bowel cancer. There has been a known feeling that the mesothelioma is largely a chemo resistant, but that is driven by a subtype of the cancer. As I said before, mesothelioma has got 2 subtypes, epithelioid and non-epithelioid. Non-epithelioid is basically sarcomatoid, which seems to be an highly aggressive one, which grows rapidly, and they are the one that's chemo resistant, whereas the epithelioid ones are slow growing and they actually do respond to the chemotherapies. You can either have pure epithelioid, pure non-epithelioid, or what most commonly people have, what we call is a mixed kind of where we have a bit of sarcomatoid, bit of epithelioid. That is why you find the cancer. If you look at the scan, oh, this is actually having a response in one area, but the other area seems to be actually responding, not responding to chemo, and that's what we call is a biphasic mesotheliomas. So just mentioning a few trials, which is basically trying cisplatin pemetrexed versus isolated chemo, unresectable mesothelioma, good performance status, etc. And again, we showed that the response rate was, when we combine chemotherapies, we can maximize the response rate to maximum around 40%. So 4 out of 10 people will respond to the treatment. And even with chemotherapy, the best overall response was around 12.1 months. With the combination chemotherapy, if you give them one agent, is around 9 months. And with no chemotherapy, is around 6 months. As we can imagine, any chemotherapy, the blood count and the risk of infection is obviously the highest risk. Again, then we said, look, okay, we've done better with the two drugs. Why don't we just add the third drug or the antibodies? So this antibodies basically stops the blood supply to the cancer, and which we have pretty much used in all cancers known to mankind, and try to see if we can help it. So we're giving the dual chemotherapy. As we can imagine, the overall survival was around 12 months. And then we said, look, how do we go with the combination of 3 drugs? As you can see, the combination did not actually make a huge progression-free survival, which means how long does it take for the cancer to grow. So about it takes giving them extra drugs makes it the cancer slow down by extra couple of months. The overall survival was not significant different, but the graph did show that there was slight difference between the it makes a big difference in terms of the how long we can make people live longer. Generally, they found yes, it was a regimen which can be used in all people. It doesn't make any difference whether you are a male, female, older, younger, mixed histology. Everybody did derive some benefit out of this treatment. In terms of now we're adding the third drug, quality of life did not actually make a big difference. So you're not making, now the biggest thing with oncology is, yes, we can have multiple treatments, but the biggest question is, yes, we can give them 3 drugs, but are we actually making them more worse, such as the emotional, cognition, day-to-day function? But luckily it made actually no difference. So it made no better, but it was actually no worse. So this combination is slightly modest benefit and does not make a big difference in terms of how they actually feel. So in summary, I think the guidelines, American guidelines would actually recommend you can have this combination as a known combination. But at the same mark, we were around early 2012, 2013, by the time this regimen was coming across, we started to have multiple agents and targeted agents that started to come around that point of time. One of these agents are EGFR inhibitors. We're starting to identify the targets. These targets are already known within the space of lung cancer. So we said, these cancers are known. Why don't we just use them in mesothelioma, which seems to have the kind of a similar biology. VEGF is another, which is basically the same pathway that we use the Avastin or the bevacizumab, which has got some activity within the blood supply to the cancer. So they've tried multiple trials, the SWOG trial with a different, now they're using the same combination of chemotherapy, adding a third agent, which basically said the combination, the response rate was actually, the historical response rate was around 41.3%. And whereas the response rate with just single agent was around 29%. There's a multiple different mechanism, and between 2012 and 2015 or 2016, there were multiple targets which was reported. Gene metabolism was another one. It is an amino acid which is the body needs for normal function. Some cancer cells lack enzymes that builds up within the cycle, and there were multiple different publications, and they were looking at different markers. This is a drug which I was involved back in the UK in a phase 3 study, which was thought to be a marker, thought to understand, okay, we can actually give this histone, the deacetylase inhibitors, and giving it on this was an oral drug, in terms of how we can actually slow down this cancer, but it did not make a huge difference, making a difference of around 4 weeks with the significant toxicity, but it was considered a negative trial. So now we were left with early 2000s. We had this chemotherapy, which potentially we could double the survival between 6 to 12 months. Then came around this multiple target agent, which one after the other was felt that we did not make a huge difference. There was high toxicities rate, and we were struggling to make a huge differences, and we were still dealing with chemotherapy until 2020. As you can see, there's lots of different pathways, lots of different drugs which was actually tried. Some of these drugs, such as bortezomib, brentuximab, etc., these are the drugs which are used in multiple myeloma and lymphomas and lymphoma treatments. There are multiple different pathways which can be explained: how the cell divides, how the cell sticks, how the cells multiply, how the cells control the activities, etc. There's lots and lots of different pathways which are altered in mesotheliomas. Obviously, as we said before, aurora kinase is another target. Multiple drugs and multiple trials have basically never translated into any of the growth. So there was lots of work being done the way we've reached in 2023 is the way we've developed chemotherapies, targeted agents, immunotherapies. And there was a lot of background work done, which is never translated into a drug, which says like, okay, this is how we actually go. Similar areas, similar pattern of growth has always been lung cancer. Early 2000, we had chemotherapies, then came the targeted therapy, then came the immunotherapies, then came the combination of chemotherapy and immunotherapy. The mesotheliomas, just because it lies in the lungs, is always followed the same growth, but it not had that much of improvement until a few years ago. Example, again, phase 2 studies, with multiple studies which done exactly the same thing, trying different targeted agents over the years. As you can see, mild grade toxicities, as we can see, as we move from chemo to targeted therapies, which is basically attacking one target and explaining how the cancer grows. The side effect profile is changing. We're not getting infections. We are getting tiredness. We are getting mouth sores. We're getting low blood counts of platelets, anemia. We're getting anxiety, a lot of other symptoms. The side effect profile is changing. When you look at those side effects, then you have to wonder, the quality of life becomes an issue, whether the cure is actually worse than the cancer. So that's an ethical question which we need to answer as well. Then came the era of immunotherapies, which has now translated into what our standard of care has now been. What we're talking, there's a PD-L1 and PD-1 inhibitors has been the standard of care. It has gone from the point starting off from melanomas, lung cancers, kidney cancers, lymphomas, and you can name it, any cancers today. This is how we treat cancers in most spaces. So generally, the body has got a tumor suppressor, what we call is the PD-1 and PD-L1 interaction, which basically stops the immune system, or what we call is the checkpoint. The body has got a different checkpoints to stop the immune system working at a higher level. What these drugs are taking off is the checkpoint. That's why these drugs are also known as checkpoint inhibitors. We are taking away the checkpoint so that the immune system can work at a higher level. Immune system fights these cancers. These drugs do not have effect on the cancer directly. These drugs have an effect on your immune system. These drugs are helping the immune system. Immune system goes and fights the cancer. Yes, we are stimulating the immune system. That's why we're potentially stimulating our immune system. Our immune system can have the different cancers, such as they can have the autoimmune conditions, such as flare of rheumatoid arthritis, flare up of ulcerative colitis. They can have rashes, they can have dermatitis, etc. Myasthenia gravis. They can have all these complications, which are basically all immune mediated conditions. Obviously, we've seen that one in mesotheliomas, 40% exhibit PD-L1 expression. Obviously, the lower the PD-L1, the worse the expression. And obviously it is a negative. It works. It is a negative prognostic marker in mesothelioma. The less you have, the worse the cancer is. So in the earlier studies, we showed that in 1B study, the drug called pembrolizumab, which is now a standard of care in many cancers, they showed given at IV dosing of 10 milligrams per kg for 2 years, primary endpoint for this one, and showed actual response. Subsequently went on to the phase 2 and phase 3 studies. 45% of the patient had a kind of response. Overall response was 24%, but you can see the disease control rate was around 76%. The side effects were very similar to what we currently are now quite used to. Immune-mediated side effects. This was a huge concern about 10 years ago. Now, as part of oncology, this has now become a standard of care. We expect immune-mediated side effects. We are very good at managing it. So obviously, what we saw in the trials is not true in the current world now, because we have got pathways, we've got guidelines, we can actually manage those side effects very commonly now. So this is basically trying to explore the evidence, the checkmate randomized studies was the one that established the combination of 2 immunotherapies in terms of the nivolumab and ipilimumab over the standard chemotherapies. The most importantly, the one of the biggest benefit for the immunotherapy is that the benefit, people who derive benefit, they continue to have the benefit. As you can see, 1/4 of the patients will continue to be alive as compared to standard of chemotherapy. So that is one of the biggest thing, that the arms, yes, 20 only 25% there, but they continue. And these people, if you follow them for 5 years, 7 years, these people will continue to have a response as compared to chemotherapies, which you will find that if we do a 5-year follow-up, these follow-up will potentially drop between less than 10% and will continue to drop as we actually go. So yes, the benefits were quite modest, but this has now become the standard of care, how we actually treat the people with mesotheliomas in the first line or at a point of diagnosis. Now the other drugs, there's always been a role of a vaccines, which is another way of immune system. We are injecting something to the body creates an immune response. Body creates an immune response. The immune cells attack the cancer, and there have been multiple vaccine trials. They've had the same fate like target cancer. We've tried vaccine trials for melanomas. We've tried the vaccine trials for any cancers, but they've not generally been a huge success. People have tried injecting the vaccine straight into the mesothelioma, into the lungs. There's been a mixed kind of a response, but this is not one of the treatment that we would go and recommend. Vaccine trials are usually done when we have exhausted all of a current treatment. Some vaccines have gone on to make the second stage of phase 2 study as well. It has shown some of the vaccines have actually failed some kind of responses, but at this stage it still remains a trial. There is no TG approved or FDA approved vaccine that we currently are allowed to give for patients with mesothelioma. Then we just want to talk about some interesting targets. They are the cell surface glycoprotein. They're expressed in human tissues, and we can actually measure. This is one of the markers that we can actually measure, and most commonly seen in mesothelioma. One of the scholars, mesothelin, we've used this to actually use in antibodies. One of the phase 1 studies has in the Lancet, they've actually shown in OncoTarget that you can actually inject this vaccine, and antibodies can actually has shown a response or an immune response in early phase 1 studies. Then there's different combination of drugs, pentostatin, and older generation chemotherapy called a cyclophosphamide. This is basically the chemotherapy backbone, is to actually assist the other drugs, not actually directly as a chemotherapy drug. This pilot study is just as an interesting scan. This is before the treatment. All the dark spots is actually cancer, and 1.6 months, as you can see, the uptake within the cancer, and you can see about 8 months how the cancer has disappeared from before the treatment, 1.6 months into the treatment, and 8 months of the treatment. One of the common things that we do need to explain is that immunotherapy is not chemotherapy. Chemotherapy goes into the body, it has an immediate reaction. Immunotherapy, on the other hand, has to stimulate the immune system. Once stimulate the immune system, cancer can look worse before it looks better. As you can see, this was before the treatment. Cancer looks worse at 1.6 months. The dark black spots have definitely increased, even if in the chest, even in the abdomen. And then you look at the 8 months, you actually get a late response into the treatment. Lastly, the biggest thing is obviously mesothelioma is still not one of the cancers that it is definitely improved. We can treat people. I think at this point it is not one of the cancers where a lot needs to be done. I think we understand a lot better. I think over the last 20 years we've come a long way, but there's still quite a way to go. We still need trial. Obviously, we still haven't been able to demarcate, okay, if you've got a limited mesothelioma on one just side, can we actually do anything better? Can we have like a neoadjuvant, which just basically means shrinking the cancer, then going for surgery? We've not defined well. And I think that's something which is going to develop in the next 5 to 7 years, because this is where currently we are with the lung cancer. And generally there is about 5 to 7 years lag between what happens in lung cancer and what happens in mesotheliomas. So it is definitely a work in progress, but there's a lot more to do in mesothelioma. And that's what I've got on mesothelioma.
Wow. Thank you so very much, Dr. Dua. That's a really great update from your previous seminar and very interesting to me. I actually recently read a paper by a lawyer about the fact that Australia is lagging behind in prevention of mesothelioma in the first place. Would that be your, would you agree with that?
Yes. And I think we have not done enough in terms of, I think we've gone down the take the route. We accepted the fact asbestos is the cause. Let's just do something like a legal mitigation risk. Let's just try and get these people, but we've not done anything a huge lot in terms of stopping the mesotheliomas, and not a lot of work has been actually being done. We definitely lagged a lot behind. I think we were doing a lot. I think the UK used to face the same situation, but they've gone and actually changed the way and how things are. So we're definitely far behind from the other Western world.
No, we certainly are. Anecdotally, a friend of mine's son is a first-year carpentry apprentice, and his boss asked him to help him dispose of some asbestos. This is a teenage child. So I just think if that's the attitude in those industries, we're going to continue to see people contracting this horrible, horrible disease.
And we also seen, I think we've seen recently the document. I think, yes, we've got a strong association with asbestos, but you also have to wonder, because the other diseases such as the silicosis, because of the stones and stuff as well, which is going to be a huge issue. So what we are seeing here now in 2023 is not what we're doing now, what we did in 1980. And there's such a long lag period. It's about a 20 to 30 years lag period from the exposure to actually the diagnosis. One of the first few patients that I treated in the first year of practice was a woman who basically had no personal exposure, no disease, but the only reason was she actually washed clothes for a son who was a builder.
Yeah.
The son never got it, but she actually got it from just washing his clothes.
Wow. Yeah, it's frightening, isn't it? People, would anyone have a question that they would like to ask? If you do, you can unmute yourself and ask your question, or you can type it in the chat. Awesome. It's because this was so comprehensive. No one has anything they need to ask. Thank you so much again for your time. That was genuinely very, very interesting. People, the slides and the recording will come to you within about a day. And hopefully you can enjoy, getting a few claps and a few waves there, Dr. Dua. Hopefully you can enjoy this again and share it with your team. This is a great topic and some really interesting information. Go and have a great rest of the day, everybody. Thank you so much. Bye, Dr. Dua.
Well, thank you, Michelle. Thanks so much.
Stop the recording.